I'm going to turn it over to Dr. Smith, who is going to be our first keynote of this morning. So I'm going to do a brief introduction, then he will be presenting, and then we'll basically go from there. So Dr. J.D. Smith is professor and vice chair of research in the Department of Population Health Sciences, Division of Health System Innovation and Research, and the Spencer Fox Eccles Center for Medicine at the University of Utah. He is founding director of the Dissemination Implementation Science Core at the Utah CTSI program, and also the Graduate Certificate Program in Implementation Science. Dr. Smith's work is focused on development and application of innovative research methods for implementation research. He co-leads an NHLBI-funded Circle, Chicago Implementation Research Center, and an NIMH-funded Mental Health Early Alacrity Research Center, and also and a Lifestyle Change Implementation Research Network Coordinating Center. So a lot of things you're leading. Wow. He is associate editor of Implementation Science and directs several methods in implementation science cores across NIH-funded center grants. He was previously associate director of the NIDA-funded Center for Prevention Implementation Methodology and co-director for the program in dissemination implementations at the CTSA at Northwestern. And by the way, one of his first jobs, he told me personally that he had that somehow relates to implementation science. You can, kind of figure this one out, is he was studying grizzly bears, I believe. So, there's some connection there, but I'll let him maybe explain further. So without further ado, JT, please.
Yeah, it's a different story. Not part of the presentation today. Thank you, first of all, to our hosts, obviously LHS and Mishar and Amy's crew. So a delight to be here today to be able to talk to you about this and also learn from the other presentations. Amy did a great job of actually covering some of my early stuff, so I'm going to skip through a couple of slides, which is nice because I probably have too many for my allotted time. So what I'm going to talk about today are some innovative synergistic methods for rigorous trials in learning health systems. Standard acknowledgements and disclosures. Current funding is a lot. I'm like 1% on a bunch of these things, so not too exciting. I am the co-developer of 3 of the methods, actually all of the methods that you'll see today. I'm actually going to talk about 4, but really highlighting 2 that you'll see on the agenda here in a second. I'm not going to talk about the features of learning health system. Again, Amy covered that better than I could, for sure. So the 2 main methods that I'm going to talk about are the Rollout Implementation Optimization Study Design, or the ROYO, which is a data-driven optimization approach that blends kind of the goals of quality improvement with rigorous implementation research methods. And then also a way of tracking implementation strategy use and adaptation, which is really critical for understanding how optimization actually works and how you can attribute changes, of course, in any sort of a between site comparison. And then I'll sprinkle in a couple of others as we go. Skip. Thanks, Amy, appreciate that. Okay, so the main idea behind the ROYO design, and this is kind of you can call it a trial design, you could call it a study design, I guess. Maybe kind of a artificial distinction between the 2, but either way, it's a design. It's really to test iterative improvements in implementation. This is part of a rollout design paper series, 2 of which are published. One was published in, these are unfortunately out of date now. The first paper there by Simon et al. Was published in 2025. The paper that Hendricks Brown led that's on scientific inferences in implementation trials came out in January. I have a paper on the ROYO design that is just recently submitted, so hopefully that will be coming out soon. And then we're working on a statistical power for rollout trials and then statistical analysis and power for ROYO specifically as well. And there's 2 or 3 other papers that we're probably going to be doing in the next couple of years as well. And these are supported by a number of centers that the main authors are associated with. So I'm going to start with the infamous stepped wedge. And I call it infamous because if you've ever done a stepped wedge, particularly in an implementation context, it probably didn't go well. Or there's just lots and lots of challenges, right? So it's a good place to start because we all know what it is. We all probably have our feelings about it. But it's a nice place to start and contrast with what the ROYO design can help you do. So of course, a stepped wedge has steps. And this really is defining the crossover point between one condition and a second condition, typically control and then intervention. In implementation projects, this might be implementation as usual, followed by an active implementation strategy that you're interested in testing. And then the wedges are your data wedges. Again, that's your control wedge and your intervention wedge, and the combination of these within and between site data comparisons gives you additional power compared to a parallel trial, which is why they are often more powerful with a smaller number of sites, which is great for implementation. Rollouts themselves are very good for implementation because they help you logistically kind of balance your resource allocation across those sites. And honestly, in most systems, when they do a big practice change, they do a rollout. They don't just do it instantaneously across the whole system for some of the reasons already mentioned. So what are some issues with the stepped wedge? The assumption, at least statistically, is that all units get the same exposure. And I could probably annotate this with like more or less the same exposure, because certainly, you know, there's some changes that get made. There's some lack of fidelity between the exposures. And so the reality is, you know, they probably really don't. We assume that. We often analyze as if they did. And sometimes we do things in the analytic side of things, like doing an analysis of learning or sequence effects, basically saying, well, did we actually get better over time? Was your position in the sequence of the rollout actually predictive of the effectiveness? And what is that related to? And of course, I think in implementation science, the dirty secret is we're probably adapting, even if we don't tell people we're doing that. And, you know, depends on your perspective. That could be a problem, could be not a problem. So what do you do if implementation strategies are ineffective or you feel like we could just do better? Do you change them? If you talk to a very clinical trial traditional statistician, they will say no. And I've had this conversation with many of them before, like, nope, the idea is you have to keep this the same across all. There are ways, you know, kind of around that. If like your first cluster is horrible, treat it as a pilot, throw out that data and move on to the next, okay? That's one way to do it, but often we don't have enough clusters to then be fully powered to do that. And so if you can change, what do you change? And how do you actually test those differences? So the Royo design was really kind of trying to address these pieces. I started thinking about this design, I think in 2019 with Hendrix Brown, and presented it initially at the DNI conference in 2020. It took me 6 years to get the paper out. I get it. Probably should have got my act together. But honestly, a lot of that was, it's easy to put together a big idea and convince people that this sounds great. It's a whole nother thing to write the details of actually what this means. And it took doing a couple of them to actually get to that point. So in a Royo design, there's a couple of different research questions you can answer, but generally speaking, the main research question is, can we identify an optimal strategy through iterative improvements of our implementation strategy between units and clusters? And I will define what optimal means, and you can have a different definition. That is actually one of the things you have to do with a Royo, is tell us how you're determining what optimal means, and I'll give you what I typically do. So the optimization or tailoring or adaptation feature in a Royo is planful and prospective. And it uses early quantitative and qualitative data to inform tailoring of strategies for your subsequent units in the rollout. Oh, we're already thinking probably like, oh, this is perfect for learning health systems, right? This is data-driven decision-making. But yeah, I'll let you fill in those holes. So some of the assumptions that you have to make with a Royo or have to satisfy is that your first implementation strategy bundle will be effective. So you don't go into the first cluster of clinics holding back additional strategies that you think are going to work. You want a multi-component bundle of strategies that you think are likely to work and are likely to be feasible. So it's a little different than like a SMART trial where you might say like, well, I really think that having a navigator is going to be very helpful in addressing social determinants of health screening, but they're very expensive. So I'm only going to do that if they don't respond to a lower touch. In a Royo, I would say all the things that you want to do that are again, likely feasible and likely to be effective, because you can always prune things as well as add. So it can go both ways. The bundle can then be tailored to improve performance. So you have to have a bundle that is tailorable. So you could think about the opposite side of this as a very simple single component strategy that doesn't have a lot of ways to adapt, not a good thing for a Royo, okay? Because you just don't have a lot of options, not a lot of tools and things to play with. A couple things that a Royo is not. It is not testing 3 or more predetermined strategy bundles. So if you have 3 predetermined bundles, just do a 3-arm trial. That's what that is. You're not using data to determine which ones you should do. You're not tailoring. You're basically saying, I have 3 different options of doing this. That wouldn't be Arroyo. It's also not a fishing expedition. It is not throwing stuff against the wall, collecting data to see what works, keeping those things, and moving on. You have to go into it with this planful and prospective approach. So I'll give a little bit of a little example here to kind of try to make it come to life. So this was a study that, unfortunately, the trial never got funded. We got funding to do the developmental work, get to the protocol and everything to actually do the Arroyo trial, but we could not convince reviewers that pediatric hypertension was an important public health problem, which continues to baffle me to this day. But this was for the implementation of clinical practice guidelines for pediatric hypertension. If you are a pediatrician, you'll know these are very complex. And so actually trying to understand how to implement them is an important issue. There is a general underdiagnosis or underrecognition of pediatric hypertension or elevated blood pressure, kind of the precursor pre-hypertension. The clinical practice guideline that was released in 2017 is very complicated, as I already mentioned. So the primary aim of this study was to optimize a multi-component implementation strategy package or bundle to improve identification of children who actually have or meet diagnostic criteria for one of these conditions. And we were partnered with Safety Net Community Health Centers. So some of the measures that we were going to use to inform optimization, not surprisingly, heavy reliance on the EHR. Which gives you pretty rapid data. There, of course, is quality concerns sometimes, but in the case of Arroyo, if you're using this for your tailoring and indication of whether things are working, it's good enough data. And so these would be things like, are you actually doing repeat BP measurements? What are the diagnostic rates? Are they increasing, of course? We were also using rapid qualitative analysis, of course, and this is rapid qual, but it is like extremely rapid qual. So it is more like actually doing like the notes and reflections, not the like full formal coding. We still do that, but in terms of the decision-making process, it's much quicker than that because as you'll see, your window for making these changes is very tight. And of course, we talked to staff, blood pressure champions. We were going to do physician interviews, and also talk to parents. I had left parents out of that. So what this actually looks like is it looks a lot like a stepped wedge, right? You have crossovers, you have data that precedes the crossover that serves as control data, and then you have implementation data. The light colored, oh, that's interesting. I'm missing my key at the bottom. So the turquoise on the left is essentially your control data. That is immediately preceding your crossover data that you're looking at for comparison. That kind of gray box where the red arrows start are implementation data, but that is the period in which you are gathering data for your optimization process. So it's very rapid optimization, and I'll break this down here in a minute. So as you can see here with 4 clusters, you have 3 opportunities to improve. So this could, and I'll talk about, again, what improvement means and kind of, what those optimization decisions are. But you can imagine if you have a really effective strategy, with maybe by cluster 2 or cluster 3, you're like hitting your targets, things are looking really good, you might be able to actually dismantle a little bit and see if you can have a more cost-effective strategy compared to the prior, and then changes some of your assumptions. But because this is not combining data and doing the typical analytic approach of a stepped wedge, you're comparing between different clusters, and so that's how you can do that. So your strategy bundle selection and optimization. This is the second methodology paper that I'll mention that was led by 2 of my junior colleagues at the time and published in Implementation Science Communications. We went through a multi-step process for how do you engage with clinical and implementation and community partners to develop your strategy package. And what happens in this is that you identify multiple discrete strategies that you identify and prioritize, again, is that likely feasible and effective, using user-centered design, a modified Delphi process that was based on the ERIC compilation study process, as well as the implementation research logic model. Some of the things that we had identified here, pretty standard stuff, training of the physicians, some workflow changes, HIT or EHR features and modifications, a little bit of task shifting, and engaging a blood pressure champion. So when you're actually doing optimization, the first thing you probably think of is, well, let's add more strategies, right? That's likely to increase your effectiveness, is one option. Something else you can do is remove ineffective or infeasible strategies. So you might learn, as you're implementing initially in a cluster, that something is either not working or we just can't really do it the way that we had envisioned. You can also change the actual strategy itself. So not get rid of it, but you can change the dose, the frequency, the actor who does it. And then, so those are kind of the three main buckets of kind of ways to optimize. So in this particular paper, we called this our clinical partner work group. It actually started with physicians, pediatricians. We had 6 that were recruited from 4 community health center organizations in the Chicago area. And all of their organizations had intended to participate in the subsequent implementation trial. In future studies, or studies since then, we've actually included people from non-potential participating health systems to make sure that the solution we came up with was more generalizable. So that's another option. We also, on the CPWG, had our research team members. These were people who had expertise in pediatric hypertension diagnosis and treatment, implementation science, user-centered design, pediatric primary care, health disparities, and use of HIT for guideline adherence. We then realized and learned as we were talking that this was not going to be solely strategies focused on changing providers and clinician activities. We had to actually do additional one-off groups to talk about just the strategies that would be done by nurses and medical assistants, as well as pieces that would be targeting or affecting the participating families. But essentially, we had caregivers of children who either had or were at risk for pediatric hypertension. So they weighed in on, again, just those kind of specific things that would touch them. So here's what the actual process looks like. I'm not going to go into detail on this just because of time. But essentially, it's pretty similar to what you might do for any implementation project planning, right? So the first thing is really gathering data from all your stakeholders, using user-centered design to understand barriers and facilitators to implementation of whatever evidence-based thing you're trying to do. We developed matrices to identify common threads and contrasts across and within stakeholder levels. Then confirmed the findings with the matrices with our stakeholder panels and prioritized barriers and facilitators. The prioritization was basically doing our multivalent coding, where a more significant barrier versus maybe a smaller barrier, and then on the facilitator side as well. We then operationalized different implementation strategies that were proposed to address those significant barriers. And then removed overlapping strategies, combined complementary ones to reduce the total number, and then specified each discrete strategy in the matrix by who would do this, what actions would they perform, when would it occur, how would we know that it's working, basically some kind of proximal outcome kind of things. And then we went back to our group to have final strategy selection, as well as tiering. Tiering is really important in the Royo design, and I'll show you this in the next slide, because what we came up with is our implementation research logic model. For those who are not familiar, it starts with the clinical practice, and for this it was our clinical practice guideline. Here's all the barriers and facilitators. You'll notice the multivalent coding followed by a bunch of superscripts that are also color-coded. The color coding aligns with the tiering. So in the Royo, the tiering is basically you do quantitative ratings for the feasibility, likely effectiveness, and in our case, it was how much should we prioritize trying to do this strategy. And what we came up with kind of in a qualitative clustering of that is tier 1, 2, and 3 strategies. Tier 1 being in green, obviously yellow in the center, and then red would be the bottom tier of the strategies. The cluster 1 strategy bundle is your tier 1. Right? It's all those things that are most likely to be effective, highly feasible. And the nice thing about doing it this way is you now have a pre-vetted list of strategies to potentially add when you go to do your optimization. And the linking approach that we do in the IRLM with our superscripts there essentially demonstrates your logic and shows how this strategy is supposed to affect the ultimate outcomes. I don't actually have the linking here, but essentially, you can think about if we are not affecting reach in the way that we expect, the first thing we're going to be doing is going back and saying, okay, well, how did we think the reach strategies that we're currently using were going to work? And then what other reach strategies do we have that might operate through different mechanisms that we could introduce. Or maybe operate on the same mechanism, but the original one didn't actually affect that mechanism the way that we thought it would. So it's a really nice way of having we call it like kind of your parking lot of strategies, which also helps basically take away that whole fishing expedition thing of like, it's not really the whole world of other strategies that you could try. You really are kind of focused here first. You're not limited typically, but that's where the focus is. So why did I go back to this example? Yeah, it doesn't matter. So the actual ROYO interval or the optimization period, as I mentioned, is a little tight. So in the current trial that we're doing, we have a 9-month period or about an 8-month period. It depends. I can't remember exactly what we're doing, but here's an example. So you basically have implementation data collection in your first cluster or first cohort. And in our case, we wanted to have 4 to 5 months of data. We thought that would give us at least some stable estimates that could show whether or not our strategies were working. We then go through a process of pulling the data from the EHR, very rapid analysis of that. Also, towards the end of 4 and 5 months, we start doing our qualitative data collection and doing our very, very rapid qual. Then we actually take that data after it gets processed by our teams and go to our community advisory boards, our implementation partner leadership, because of course we're not going to propose changes that the leadership is not on board with. And then our strategy optimization work group essentially comes up with a final proposal. It gets signed off by the health system and by our community advisory boards. That's that double-sided arrow there. And then you have a couple of months to prepare to implement those changes. So your typical preparation for implementation, of course, is probably going to be an IRB change, any sort of training or additional like EHR modifications. And some of these things, if you know you're going to make the change, you can obviously get started before that. So it doesn't have everything get approved 2 months before, but that's where you really need to have that package for the next cluster done. And that happens 2, 3, 4 times, depending on how many clusters you have. There was one study that I was part of that was at UCSD, led by Nicole Stadnick and Borsika Rabin, that they did this process in about 6 months, but the amount of data that they had was a lot less. They were doing 1 clinic at a time, not a bunch of clinics. So that increased feasibility and they were able to do it on a much more rapid timeline, but that's a bit more of like kind of a pilot ROYO. That was not a fully powered ROYO. So again, this is data-driven decision-making. And then your IRLM really gives you the justification and the reason for the different changes that you make as you go through the optimization process. And again, you can add new strategies, change effectiveness, all those different kind of things. So the definition of what is optimal can differ depending on the needs of the health system, depending on your research question, depending on the actual science of what you're implementing. But when we start thinking about the analysis of ROYO trials, that helps us get to what we might consider as optimal. So in this example of the pediatric hypertension guideline implementation, the primary outcome was the rate of accurate diagnosis. In our system, the baseline accurate rate was less than 10%. So they were missing 90% of kids that actually met diagnostic criteria. So we had a potential to move up a lot. So we modeled essentially this trajectory over an 18-month period where we thought that our initial cluster would likely be able to move the needle essentially about 20% points, 15 to 20 percentage points over 18 months, which doesn't sound great, but that's still a pretty huge effect. And we thought that if over the course of optimization in our later clusters, we probably would be able to get to about a 45% rate, which is definitely much better. So again, like those kinds of rates and assumptions and targets are going to vary by the type of intervention, the baseline starting rate, et cetera. So what you can do with this data is a number of things, and this is not even the whole list of things that you can do, but essentially in this trial, we had proposed to do a time to criterion, comparing the initial cluster 1 to later clusters using a non-parametric test. Or you can actually do all clusters using a Cox hazard model. And so the time to criterion for us was time to 25%. And so again, we thought that at least by 18 months, we'd get to 25% for that initial cluster, but we could do it a lot faster. You could see by the 5th month, we're hitting that for our furthest cluster in the rollout sequence. You can also do an improvement over time between clusters using multi-level trajectory analysis. This is absolutely the most powerful way to do it. As you can imagine, doing a Kruskal-Wallis non-parametric test, not terribly powerful, but a multi-level test with the amount of data that you would have here actually is very well powered. And the Cox hazard models are actually fairly well powered as well in this context anyway. So that will be the topic of one of the analysis papers that we're planning to write. So the other part that's really important is cost. I personally would not do Arroyo without having a cost analysis. And in this particular case, what you'll be using is what are called ICERs, or incremental cost effectiveness ratios, which essentially is the difference between the cost of the strategies between cluster J and cluster J minus 1, and the difference between the effectiveness of those two. And then you usually have to do some sort of a correction to put them on the same scale. So in our case, it was cost of implementation per 100 children, so that if we had different cluster sizes, you weren't affected by how many kids you actually saw. And then also the effectiveness, again, was our primary outcome, which was the improvement in diagnostic rate. It's really a combination of these two things. And as I kind of mentioned before, you could continue to add strategies probably till you're blue in the face and keep eking out little bumps in your effectiveness. But at some point, those become way too costly and just lack cost effectiveness. So it might actually be the case that your cluster 2 or cluster 3 becomes the optimal cluster, because adding more expensive, less feasible, less sustainable strategies might have bumped things up a little bit, but if they're not cost effective, they're not something that you'd want to propose moving forward with. I could also see a scenario where like cluster 2 and 3 are pretty close. And of course, some of those strategies would, the strategy selection or choice between them might actually depend on the capacity, the resources, et cetera, of the context. And you could say, basically, you have a choice. If you have the capability to do navigators, practice champions, and X, go with cluster 3 bundle. If not, maybe cluster 2 is the right choice for your organization. So just a lot of information about what you could choose and what are important. The one thing that you're probably already saying or are wondering is, in most of these, because we're making multiple changes, you really have a hard time attributing any difference between clusters to a single discrete strategy. I could see a situation where maybe you would say, well, let's only add one strategy to see if this one thing actually is the driving factor and the reason we have a difference between clusters. But in most scenarios, I think you're probably going to be changing at least a few things across your discrete strategies. And so that causal inference for an individual strategy is not possible. It really is bundle level or package level strategy interpretation. So some methodological considerations for the Arroyo. Of course, strategy selection at the beginning is absolutely critical. You want to do this a priori with your partners, have the initial package very well justified. I don't do an IRLM for all of my projects, which is maybe kind of weird, but as the lead developer of it, I use the IRLM as our main tool for doing this. There are other ways to do it, of course. And I already mentioned this too, what other discrete strategies do you put in the parking lot? Having that pre-vetted list that has all of the logic really helps you make decisions about what to change and what to add so that you can hopefully increase the outcomes that you're trying to do. How many clusters and steps? Do you need 2, 3, 4 attempts at improvement? So more evidence-based strategies may need fewer bites at the apple. More complex strategies might need more. Who knows? You're also going to be limited by your timeline of your project period, how many resources, how many clinics you can recruit, all those different things. But in terms of actually trying to fit this within a 5-year project period, even with a condensed optimization interval, it's pretty hard to do more than 4 clusters. So you're looking at either having 2 or 3 opportunities. What's your rollout schedule going to look like? Of course, you need to ensure sufficient time between clusters to do that optimization process, and it can vary depending on the complexity of the data and how many stakeholder groups and things you need to have input on to make that optimization decisions. What are your tailoring metrics going to be? You want to actually select metrics that, of course, are sensitive to change early on, and they're actionable. Like, you don't want to, be basing decisions on data that really don't point you towards what kind of strategy change is needed. And you need to have analysis methods that are rapid and informative of needed changes. I only mentioned sort of the primary overall analysis methods. For the actual analysis methods that we're using in that optimization period, we're doing things like short control charts, statistical control charts, of course, a lot of qualitative stuff. But really, you need to do something that's conducive to the type of data and the amount of data you'll have. And then a priori determining what are your thresholds, or at least your process for doing your modification decisions. Again, this is not just Wild West, haphazard, do whatever feels good at the time. You really want to have a protocolized way of making these decisions, and having potentially either targets, thresholds, or another way of saying, is this good enough? And in our current study, we rely very heavily on what our partners want. So we actually had them say, well, what would be a good rate for us to get to? And that will be at least our starting point of saying, well, we didn't hit the rate you guys want. Is this too far below that we need to have action, or is it close enough that maybe we don't need to and we can move forward? And of course, this process needs to be replicable and transparent. It is so critical to this type of design. It really needs to be something that's spelled out and someone could do again. And then strategy tracking and documentation between clusters. Again, causal inference is a little difficult with this type of design, but regardless, if you're going to make any conclusion about what led to differences between clusters, you're going to have very clear documentation of what strategies were used in each cluster and how modifications happen. And that's what brings us to our next method, which is lists. So LIST is the Longitudinal Implementation Strategy Tracking System. We developed this, I have to do this every time because NCI gets mad at me if I don't. We used funding from the Impact Consortium, which was funded by NCI. This was about improving management of symptoms during and following cancer treatment. It was 3 quite large centers that did symptom monitoring and then intervention across different health systems, and then there was a coordinating center as well. My CTSI also has contributed quite a bit to this, and I had a lot of collaborators that helped. So the LIST method is really kind of 2 pieces. These should probably be familiar to any implementation scientists in the room. When you initially populate your strategies, you have to do the Proctor, Powell, and McMillan specification. So you have to tell us what is the name of the strategy, what is your operational definition of what it is, and then tell us all the pieces about who does it, when does it occur, what's the implementation outcome you think you're actually going to be affecting from this, and then providing a justification. Our justification really is basically what barriers did you think you were addressing by having this, and what facilitators are you leveraging? So it's not super complex, and of course you can use other methods for kind of expanding on that justification outside of the LIST system. Once you actually have all your strategies entered and you start implementing, we use a timeline follow-back procedure, which is basically meeting every 1 to 3 months with your implementers to discuss what is happening. And we do this typically, naturally, but what we're going to do with the LIST method is basically force a bit of structure into that. So when you actually meet with them, you actually review the strategies and you review the details, the actual specify pieces, and say, is this still happening? And nobody will be surprised that when you do this, you're like, oh, I didn't realize I was supposed to be doing this every week, or oh, actually so-and-so that we said was going to do this isn't doing it, it's somebody else. So all those things get tracked. Whenever a modification or a change actually is noted, the system, you click, okay, strategy's been modified. And then this goes into a bunch of frame-IS questions. So the reason for modification, and there's pre-populated things like it was ineffective, it seemed like it was infeasible, some of those things. Was this planned or unplanned? And what we say by planned or unplanned is, was this according to protocol, or was this something that, oops, we didn't realize this was happening, unplanned modification? Exactly when did that change occur? And then who made the decision to make that change? In any situation there, it's going to kick you back to the specification to change it. So you're going to end up with a stacked data set that basically has timestamps of, here's how audit and feedback started, here's the first change, here's the second change, here's the next change, and then you're going to see planned, unplanned, et cetera. In the context of Arroyo, you hope that most of those are prospective and planned changes that happen between clusters, but not necessarily, of course. Okay, this is worth like very quickly going over. So the process for populating, what we typically have done is reviewed the full list of ERIC discrete strategies as a prompt. And the reason for that is if you only say what strategies are you doing, you get only the strategies people are interested in and the strategies that are kind of new or novel. Most of the time, systems are doing other things that help support it too. And so you really want to get a comprehensive list. You'll not be surprised that the average number of strategies so far is about 35, which may seem insane, but that's also discrete strategies. There's a lot that are bundled that have multiple components. I'm counting down to the discrete level. You then enter your strategies into an Excel spreadsheet. That's the easiest way to manage all this stuff. And then you confirm your list elements with other team members, calendars, meeting notes, et cetera, if you're already implementing. Yeah, whatever. The rest of it's kind of self-explanatory. So the process for updating, we do the check-ins with implementers. We try to actually like do this within study meetings. So basically like every 2 months, one of our typical implementation study meetings is really a lists focused meeting. Somebody else is usually in charge of kind of paying attention to any changes that happen. So you're impromptu like saying like, oh, that sounds like a change. Let's go enter it in lists, even if it's not technically a lists meeting. We review entered strategies to assess for changes. There's a really cool dashboard that I'll show you that really facilitates this very well. And then sometimes we will send periodic emails to implementers to ask them how have these things changed. It is not a survey. It is not a bunch of additional data collection. Even for the most complex projects, the average amount of time that people spend on lists-related activities is less than 20 hours per year. Okay, so it's not a huge lift, even though it is a boatload of data. The who and how, our study team members are implementers that are familiar with the strategies. That's why we don't have to send out a survey. You have implementation, people who are out in the sites, they're talking with the implementers directly, or they might even be an implementer in some cases. You often have investigators, of course, coordinators, site PIs. It really does help to have your implementation scientists there. We're working on a potential AI-based solution to that, but I'm dubious. We'll find out. Then you have to review your documentation, which is all those different pieces or places that this information might live. I'm going to skip this tracking and fidelity because it's kind of straightforward, but I will share the slides. Can you use lists? Yes, you can. It is available. It's free. It is hosted on the HIV Implementation Science Coordination Initiative website. There is interoperability with the implementation research logic model. So we have a web-based IRLM tool. If you enter all your strategies, link them to your barriers and your outcomes, you can populate lists with that. It does not go backwards, unfortunately, but at least if you start with an IRLM, all the information you enter there can get pre-populated, and then you just get prompted to enter all the rest of the information. So here's what it kind of looks like. The really cool thing is that you get to specify a project-specific or project-tailored dashboard. So one of the things that you do when you first set a project up is you enter key project dates. So in this case, we had a project, and some of the things you have to do are when did the project start? When did your grant funding start? When was your go-live date? And then you can enter anything else out after that. This is a Royo example. It's fake, it's a demo, obviously. It's called the rolled in trial. That was my colleague who came up with that. But you can see like basically there's 4 time points for when the different rollouts happened. And the strategies are actually done in time of when they start. The orange indicates when they were discontinued, and you can see even that waiting room kiosks was discontinued for a period and then restarted, which does happen in some cases where you catch, essentially that they, stopped doing something they should have continued. And then there's little yellow lines you can see in the pre-implementation training bundle. So this bottom box here in the gray is actually, you can indicate bundled strategies as well and define all the discrete actions or strategies within the bundle. But any modification that you make gets a little yellow line. And you can click on that strategy to get the log of all of the modifications. So in some cases, there's strategies that have been modified multiple times, and you can just click on it and get that log. I don't have time to go through the whole demo of the dashboard, but it's pretty cool. And it does really facilitate you doing that review. You can just pop it up. Every single thing is clickable that takes you to the data entry. So it's pretty neat. So some concluding thoughts, not surprisingly, LHSs, I think, really offer a unique architecture and climate for doing implementation trials, but you have to do it using trial design methods that actually are conducive to the learning health system. And I think Royo is one example that is particularly well suited. Methods really do need to leverage the characteristics and features. So again, the Royo really uses data-driven optimization, which aligns with, kind of the continuous learning and data infrastructure of a learning health system. Multiple perspectives, giving you input and helping you make decisions around optimization, ongoing improvement, and actually the Royo is rigorous for actual hypothesis testing versus kind of if you were really doing this as a QI project, you don't really have the rigor and the potential of doing a fully powered trial in the same way. So it kind of marries the best of both worlds, I think. Clearly having some limitations on either side, but that's okay. We have to make compromises. And then the list tool is really critical for understanding what caused improvement and informs what and how to adapt the strategies in the Royo. It also, I think, and I've gotten this feedback on a couple of recent grant proposals, that in the summary of discussion, people have noted that they love lists for transparency and potential replication, which again is getting more emphasis currently in review panels. So that's very helpful. And Royo trials really do add rigor and generalizability to what would typically maybe be considered a more quality improvement initiative. So a really good potential solution for that. And I'll leave you with a beautiful picture of Utah. I left 5 minutes for questions. Yeah.
This is great. I really love what you're doing here. I have a question about the very last thing you said, which is that there are...
Oh, we have mics. Hold on. Yep. Sorry. I'm getting signal from the back. Nope. Yeah, one of those works.
Yeah, this should work. Thanks. Really love what you're doing with Royo. I have a question about how you're thinking about generalizability in the context of Royo. So in sort of standard way that we do optimization via factorial experiments, micro-randomized trials, and so on, generalization really happens at the level of components, right? You're getting a main effect on the effectiveness of a component that might transfer to other contexts. That's not clearly how things are working here. So I mean, especially when you're trying to sort of think about the distinction between QI and what Royo does, where is that generalization coming from and how you're thinking about what transfers to?
Yeah, there's kind of two pieces of that. I think, the really going into it with a package that has been informed by multiple stakeholders and even those who are not implementing, so that you're not developing and testing a local solution. That's one thing, is like just actually the way that you do the Royo and the preparation that goes into it hopefully gets you to transportable solutions. The other piece that I alluded to a little bit is that if you really do a good job of documenting how decisions were made within the Royo process itself, and giving people more or less guidance on where you can be flexible, that helps somebody actually pick up and tailor. So I think that's one of the problems with a lot of our implementation designs now, is that you test a package and then that thing, the package then becomes like, well, we have to do this exactly as they did it, otherwise it's not that thing. And I just think that's very unrealistic, and it's just not very practical. So there are ways to make this more of a practical approach, but it is, again, there is those trade-offs of it's not as powerful for causal inference, but it is a lot more practical, and hopefully it gets you to solutions a lot quicker. That'll work. Solutions that'll work for particular health systems a lot more quickly. So there might be a very clear winner in terms of which package of strategies was the one that was optimal in this context. But as the researcher, I would not want to put that forward saying you have to do it exactly like this. It basically is, this is the one that worked best for us. Here are other things we tried. Here's the effects that those seem to have had. This was found to be not very feasible in our trial, but that doesn't mean you can't do it. And I think the other piece too is that this is almost a strategy in and of itself. This is almost just a tailoring or optimization strategy. So following this process for doing it within your own system, someone else's findings and like where their bundle started and all the different pieces that they had could inform how you do it in your system. And you might come up with a slightly different optimal package, but the actual rigor of the trial method more or less operates like a strategy to help you get to that. Really good question. Yep, we have 20. Yep, I'll be quick.
Oh, one question that was submitted, I think, online. Royo and the ICER seem to be optimal, but what would be more appropriate for a low-resource health system? Is there a Royo Lite for systems with few staff, small budgets, and multiple competing implementation priorities?
Yeah, probably. I haven't really thought too much about it. We have done pilot Royos, as I mentioned already, with like single clinics. As like you roll out like within a single, hopefully fairly homogeneous health system, you could basically treat each clinic as a cluster. That's not going to be fully powered for like an NIH grant R01, but that would be a way for lower resource systems to probably do a Royo or Royo type project.